coracoid is hard for me. Still.
From here, just center on the coracoid, and you can leave your neutral again.
Oh, we're good.
Oh, it's coming?
Yeah, let me check.
Okay.
Okay.
But,
As you come down, that's the coracobrachialis muscle.
oh, it's coming.
There you go.
Okay.
There you go.
So,
Nice. Yeah, we're on.
guys, today, good morning. We're gonna start live streaming on shoulder today. So our chief residents are presenting shoulder joint. Okay.
Okay.
Let's start. Can you see?
We
it?
had a rehearsal before, so we'll say it again. So here's home base. So that's the long head of the biceps tendon in the bicipital groove. On the left side of the screen, we have the subscapularis in long axis. That's subscapularis muscle and tendon junction. On the lateral aspect of the bicipital groove, you have the supraspinatus. Scanning inferiorly, we have the pectoralis tendon coming in and inserting right next to the biceps tendon.
Speak slowly.
Sure. As we come up and scan superiorly, we have to tilt the probe as the biceps tendon invests into the glenoid. We try to keep the biceps tendon and adjust for any anisotropy as we come in.
The broomstick. The biceps.
So you say broomstick?
Yeah.
Go ahead and internally rotate a touch.
The biceps tendon comes. You show the biceps tendon.
Yeah. So the biceps tendon is now on the left side of the screen. There we are. And go back to neutral. Okay. So it's the hyperechoic portion, and we would be looking for any circumferential fluid that might indicate a joint effusion that's extending to that portion. As we can, now we'll tilt the probe upwards and kind of flatten it out again. And so now we're out. Now we're over the subscapularis. You still see the biceps tendon here, and we now are seeing the coracoid come into view. And so this would be a place to evaluate for subcoracoid impingement of the subscap. And go ahead and do some external rotation.
Shoulder part
Okay. And this would be an area to see if there's any engorgement of the bursa.
The other way.
Just bring it around here so you're like
There you go. That's good. You can relax now. Thank you. We'll get the coracoid into view, and keeping the probe in the transverse plane, scanning inferiorly, we'll see the coracobrachialis muscle come directly off in the center of the screen.
Good.
Coming back over the subscap, we're going to rotate the probe 90 degrees to evaluate the subscap now in cross section. So it is normal to see slips of the subscap tendon. Those are not necessarily teres or pathologic. At this point, we continue to scan superiorly, get over the AC joint, at which point you would adjust your depth and focal zone. This is an area not just to evaluate for AC joint osteoarthrosis or for joint effusion, but you can look for distoclavicular osteolysis or the geyser sign, which I believe is due to effusion. Coming back down again, coming back to our home base. It's actually a good depth right there. Mm-hmm. So here's the portion where we know we've evaluated the lesser trochanter, but if we want to evaluate the greater trochanter, we want to look at the supraspinatus. We have to get the patient into either a crass or modified crass. So go ahead and go into modified crass. Hand into the back pocket. Okay. At this point,
Go ahead. Turn and show to the people what they
Sure.
mean by the press. One time and then go back to
Sure.
original position. Yeah, good.
so in this view, we're looking at the supraspinatus as it is in long axis, and we should be able to get the acromion coming into view on the left-hand side. So that is the supraspinatus tracking underneath the acromion. And so we would be looking for any sort of cortical irregularities that could be associated with chronic tearing. You'd be looking for hypoechogenicity that could be a result of tendinosis. You can put Doppler on there to see if there's an acute tear. And then as far as classification of tears, Jacobson does a good job of running through this and saying whether it's bursal-sided, so that would be the superior aspect of the supraspinatus myotendinous junction, and then, or if it's articular-sided. And then anything in between is considered interstitial. And then do full crass. So basically all the way underneath.
All the way to
Yeah,
the-
yeah. And so this would provide a little bit more comprehensive overview, but can also be very uncomfortable. AMSSM in their videos, they have the patient lying down to do this, so that when you have your arm internally rotated, it's just against gravity, and you're not having to actively get it there. There we go. Nice supraspinatus tendon. You can go ahead and have your arm back in neutral. So now that we have our probe over the supraspinatus tendon, and on the left side we have the acromion, we can have the patient actively abduct the arm to look for subacromial impingement, or you can help. Go ahead. I got you. There we are. And you'd be doing this for a couple of reps to see if any fluid would build up.
Chromium here on the left side of the screen. We're seeing the supraspinatus tendon kind of gliding underneath the acromion here, which is the most common place for impingement to occur. Which looks good.
It does.
You want to try mine?
Sure.
we could do another evaluation for sure. Okay, and that would be taking a look at the supraspinatus. We know that we lose the supraspinatus as it tracks underneath the acromion. So that's the area where we're now looking at it in the distal aspect, looking at it modified crass, and crass gives us two different views of the same tendon, and also here as well. If you go back into full crass, you can actually, I haven't not done this one, but you can actually evaluate for infraspinatus as well. So the way to tell there is that, say we're here, and we're looking at supraspinatus, as you track laterally, the trochanter should flatten out, at which point you'd be over infraspinatus, and then ultimately over teres minor. So here we track, now we are anterior, and while we're looking at the supraspinatus insertion here, you can actually, like all the tendons, you can flip 90 degrees and take a look at it in cross section as well, and see the slips now coming out at you from the screen. And so if we track laterally, we should be able to start seeing these infraspinatus come into view as well. And so this should start to be the infraspinatus, which is on the middle set of the greater tuberosity. As we come even more posteriorly, we should be evaluating for some of the, there we are, there it is. So that would be teres, infra, and back up to supraspinatus. Okay? Yeah.
10-day practice.
Absolutely, we have one more
So-
area to go. So for posterior evaluation, so you bring your arm back to neutral. You have excellent shoulder mobility, by the way. It doesn't seem to bother you.
All the yoga.
It's all yoga. Could I have some gel, Jordan?
I think we put instructor. A plus, C minus.
C minus.
That's what I was going to say.
Harsh.
Harsh crowd this early in the morning.
Yeah.
Could you increase the depth, Jordan?
Yes, I can.
So this is something, actually, Dr. Kim, you showed me a while back.
Yeah.
So you see that basically ski slope in the bottom of the screen.
Mm-hmm.
So right now I have the left side of the screen is superior cephalad, and then the right side of the screen is inferior. Basically, on the left side, if you look at the hyperechoic central tendon, that would be the infraspinatus. So if we want to center that in the screen, then turn transverse on it, now we're looking at infraspinatus, and we're looking at the posterior aspect of the glenohumeral joint. Looking at infraspinatus insertion, and so right here, if we get just a touch more depth, this is where we would look for, so,
Wish we could have two camera.
yeah. Here we're looking at So now we have a nice round humeral head. We're getting that to view. And then the triangular shaped piece to the bottom left is the glenoid labrum. I'm sorry. And then actually over to the left even more so, if you were to scan, if they can get into view, that is the spinal glenoid notch right there.
The nerve. The nerve.
Yeah, so that's suprascapular nerve entering into the infraspinatus to innervate it. Okay, and that would be infraspinatus. Now coming back to the view that we were in, trying to get that ski slope view. And so we see the hyperechoic central tendon of the infraspinatus on the left. Now we're going to track a little bit inferiorly and now cross. And it's worth noting that as you evaluate for teres minor, you have to be a little bit oblique. You cannot just be strict transverse because the way the muscle comes up. It's much smaller than infraspinatus.
Can you show?
Yep, absolutely.
Good.
Coming in. There's the tendon. Oops.
Yep. And if we scan superiorly now, we'll see the bigger infraspinatus muscle. Much bigger, much smaller teres minor. And then this is where we would perform a posterior glenohumeral joint injection. You want to show with the cursor where we would attack?
There's labrum.
Yep.
So the injection goes here.
Yeah, so you go just basically just lateral to the labrum and get underneath the joint capsule, and you'll see distension of the joint capsule and the fluid tracking underneath that area.
Labrum hurts though,
Labrum hurts.
so don't hit the labrum.
And then if you actually come up now onto the supraspinatus, so you can palpate for the spine of the scapula and get the probe over here, we should be able to get the suprascapular notch in there. I'm trying to get into view. See it coming into view ever so slightly. Can you throw a Doppler on? There should be an order in there.
This one.
See it. We're going to put more down to show.
There was just a link.
Oh, there.
Yep, there it was there.
You got it?
There was something there.
Funny.
There, just stay there.
Just as we need to talk a little bit. We had the same minute. There.
Yeah, I see it. I see it. Ever so slightly.
Yeah.
And so that's the suprascapular nerve going in. I'm sorry. I think I misspoke before about spinal glenoid. I did. So spinal glenoid is axillary nerve, right?
No. So the suprascapular notch is one on top, right?
Yeah.
Spinal glenoid is below.
We're
wait.
inferior.
So it
You're
has to be
right.
X-line, right? Because the supraspinatus nerve force is not.
Okay, then yeah, you're right.
Yeah.
You're right.
So spinal glenoid
Yes,
is axillary. I apologize. I knew I
Yeah.
misspoke.
Accepted.
Blame it on not getting the second cup of coffee yet. Yeah. So now we're in spinal glenoid right there. There you are.
This
Your
one?
vessel. Yeah.
Oh, and then I see. And then
Yeah.
it's gonna come to the median.
Because this is an area for entrapment.
Correct.
Okay, so that's anterior, lateral. We looked at the four muscles of the rotator cuff. We looked at the acromioclavicular joint, the glenohumeral joint. We looked at the biceps tendon. Those are the main areas for evaluation.
Perfect. I think that's all
So
the
now
basics.
you teach. Who's gonna do it, Jason or Jordan?
Jen,
Go for it, Jason.
do you want to get some gloves?
Yeah, grab the gloves.
Should we also bring people into the other room and do it, or no?
We can do that too, yeah.
Yeah,
Split
do
it.
Do you want
We
to start
open with
first?
the other
Or
one.
do you have gloves?
It's okay. I mean, I was gonna go in the other room if people want to go there.
Yeah,
Let's do it.
that's good idea, split it.
Just so we can split up.
We open to the other room.
Awesome. You. Okay, so we'll start with the anterior. With the arm externally rotated.
You stay there. I'm gonna learn.
Jason, probably
Yeah.
easiest if you're trying to find the rotator interval, just to have the arm neutral.
Oh, okay, got it.
Depth.
Yeah.
Okay.
And we gotta adjust your depth and
So this home base.
it's actually down, scan inferior a little bit.
Here.
And then which side do you have left on the screen? The notch
Notch
should
is
be left.
Yes. So I
Okay.
should flip it. So
If you want.
medial is-
Yes, whatever you want. So we're consistent with the prior video.
So we're gonna look for the biceps.
Yep.
Yeah.
Come down a little bit.
Oh, right there.
Yep.
Here it's
Sitting,
coming.
right? Yeah. And if you
Yeah, that's good. It just helps.
Still anisotrope. You see it? Oh, there. So when you see this broomstick, you just showed the one that's the biceps tendon.
I see.
You show some stick like this.
Got it. And then I
No,
should-
this one, this one, coming now.
Okay. Okay, and then I should go like vertical to.
You can try
Yeah,
to
you
vertically
can
to
do
see
a
how.
mixture now and just see for any irregularities
So it's gonna look a little funky. Is that what you're looking for? Or are you looking for a bicep?
I think biceps tendon, he's
Yeah,
like a
in the
vertically.
groove, yeah.
You could definitely do that.
Is that it?
and
Where
you might
Dr.
have
Kim is
come
pointing? That one, right?
on it.
You have to do transverse to show the broomstick one.
So.
That's your best view of the.
Yeah.
Perfect. And then
So what I
let's
do,
adjust the depth just a touch.
I don't know, it might help you, it might not. What I do, I literally put my finger
And we have
in
too
the
much change.
center.
Yeah, that's
And then I
right.
rotate around
Right.
my finger because otherwise I come off
Got
of
it.
it.
Okay, so I'm rotating.
Yeah. And this way you
Yeah,
make
it's
sure
a full
you're
tendon.
exactly where
Got
you
it.
need
So
it
that's
to
the
be.
whole tendon.
We
Oh,
should
that's.
see a nice fibular biceps tendon. The key is
Yeah.
as
Fibular.
it's tracking.
Jared taught me to swivel around.
Yeah.
So as it's
Uh-huh.
tracking, it's difficult to see
Tracking up.
because it's going to go in intra-articular.
So that's the tendon, right? And then so if I go superiorly, I should see it into the capsule, right? The labrum.
I don't know if you can see it.
Okay.
The attachment. Yeah,
Are you
because
going to
the
supinate with the process?
Where
You're
the
looking to the
superior-
original with the biceps?
yeah,
superior
where it
to
attaches
the-
to.
Draw for a
Yeah,
sec.
go for it.
Process.
Here.
Yeah.
So let's
Something,
back
yeah.
too short.
So that's tendon.
There you are. See that
Oh, the
What is
nice fibular
it? Oh,
structure?
hold on a second so I can use cursor. So this one, right?
Uh-huh.
This is the origin of the
This is
biceps, the
the
long
bicep
head.
tendon. Yep.
Because the short head starts from the crocoid process.
We can't visualize all the way to the origin because the origin is supraglenoid tubercle.
Tubercle, yeah.
So we can't get all the way there, but we can at least see until it goes
I think it's almost
intra-articular.
starting here. Yeah, here. You can see the tendon is moving. But this
Here.
is.
Okay.
But this one is looks like there's no tendon, right?
Yeah.
It's anisotrope. You
So
have
I
to
should
just twist.
fan it, right?
Yeah, make
There it
sure.
is.
There you
it's-
are.
Yeah.
Beautiful.
But
Okay. And then next, I'll externally rotate to find
Yeah.
the subscap.
subscapular.
Which
Beautiful.
is that right into
Yeah, that's
the-
subscap.
Okay. And then you would go.
Then you internally, externally rotate. Yeah.
Try to get because you're evaluating, it's a dynamic evaluation, you're looking for impingement, get the coracoid in the view.
Got it.
Right there.
So more.
And now clean
medial.
up that tendon.
Okay. Let's see. Right there.
Yep. And now you're looking, that's perfect.
So if there is impingement, what happens? How?
Yeah, what do
There
you
will
see?
be a little bit of
So,
fluid
prob-
coming in here. There will be like a bulge, right?
Or
I
the
think so.
swelling?
Yeah.
Yeah.
And then on the superior aspect of the tendon, typically that's where the bursae sit.
So
There is a
how
recess.
do we call it? Recess. This area. This is
Clean
where
up
the
the
coracoid
coracoid.
process.
Clean up the coracoid, so go ahead and tilt the aspect.
Yeah.
There you are.
So this space, right? How do we say?
I'm not sure what to call that.
Subcoracoid?
I mean, it seems logical enough.
Yeah.
People will laugh at us.
Hey.
But that's all right.
Oh.
And then
So
did
there
you see
is
the
no fluid.
coracobrachialis?
Yeah.
You see it.
Yeah, if you go a little bit lower, then you will see coracobrachialis and short kind of biceps starting from
Center of the coracoid?
coracoid.
So center the coracoid in your screen.
Yep.
Yeah, if
So
you're,
look at me.
So
there you go, center it. And now, as soon as you scan inferior